Dr. Elwing, Dr. Shaw, how does the presence of portopulmonary hypertension with or without treatment impact those patients who must undergo liver transplant?
So it is an extremely important thing to know about and manage before patients can be transplanted, and they have very great interactions. We know that our patients with portopulmonary hypertension are at high risk for anything, including surgeries. And we also know that liver transplant may be their best option for improvement. We know that if we can get a patient to the point where they're improved hemodynamically enough to allow them to be transplanted, many times they improve or stabilize, but their pulmonary hypertension may not fully resolve. So we go into this understanding we're hoping to have an impact on their liver, of course, by liver transplant, but we may or may not fully resolve their pulmonary hypertension, but we hope to improve it and stabilize it. And when we pursue transplant, we only do that when we meet criteria for controlled disease. And we're going to talk about the hemodynamics. Dr. Shaw is going to go into what criteria we're using to say someone is safe to proceed. In contrast to some other forms of lung disease and liver disease, we don't transplant solely because someone has portopulmonary hypertension. They have liver disease, and this allows them some added exception points to allow them to be a transplant candidate earlier than if they didn't have portopulmonary hypertension, because they oftentimes are more complicated, sicker, and we can't allow them time to get worse, or they will get out of the window where they could be a transplant candidate. So these things have great interactions, and we have to respect both the liver disease and the portopulmonary hypertension to allow them to be a candidate. If we're not able to capture the person, maybe they're too sick, or maybe they don't have the social support to use the medications they need to improve their pulmonary hemodynamics, they may not be able to reach the point where they're safe to transplant. Uncontrolled pulmonary hypertension in the setting of liver disease is a true contraindication to proceeding. And can you tell us a little bit more about that?
Yeah, one of the things that happens if it's not controlled is that the right heart gets affected in the operating room. And so when they have portopulmonary hypertension that's either unrecognized or not controlled and optimized when we go to the operating room, during the liver transplant there is a lot of a load that occurs in the lungs and in the heart, and patients develop right heart failure because of the backup of pressure from the lungs. And that's a surgeon's view of looking at it, but the bane of our existence is right heart failure, because patients die if they develop right heart failure either in the OR or subsequently right after the transplant. So part of the goal of controlling the physiology in the lungs is to make sure that the heart remains stable not only throughout the course of the operation, but then for months and years afterwards. But just the insult of the operation can lead to acute right heart failure, for which then an anesthesiologist can actually maintain blood pressure or maintain hemodynamic support for us to continue the operation. And that is can be sudden and quite severe, to the point that sometimes we don't get out of the operating room. And the physiology is shown on this slide, but you can see that it first starts with high pulmonary vascular resistance. It leads to dilation of the right heart. It doesn't squeeze as well. You then develop ischemia, and essentially that leads to hypotension and really no pumping effect of the heart. And on our end, in the abdomen, the liver essentially is right next to the right heart. The liver then becomes either, whether usually it's the new liver at this point, because it's the stress of plugging in the new liver becomes massively congested because it doesn't have a way to breathe by going into the heart. The blood flow doesn't have a way of breathing, and the liver becomes congested, and that leads to essentially a catastrophe in the operating room.
So mortality is a realistic, serious concern.
It is, and we've developed over the years, our community has developed some guidelines of what is acceptable and what's not in patients with portopulmonary hypertension that need a liver transplant. And in numerous studies, what we have found is the mean pulmonary artery pressure greater than 35 is a big problem. So we try to get the pressures below 35 based on a right heart cath that Dr. Elwing is involved with, and that's kind of our marker, the mean pressure getting to the operating room. If we're in the operating room and there's a high mean pulmonary artery pressure, we then use the PVR assessment in the operating room to try to determine, is this portopulmonary hypertension? Is this just volume overload? Can we proceed or can we not? And a PVR greater than 250 is something that we use, or less than 250 is acceptable. Usually we like to base that on a right heart cath, not on something in the operating room. And I've called her a couple times from the operating room with high pressure saying, what do I do? Because it's someone that we didn't have diagnosed. And that's really a tricky situation for me as a surgeon. We have a liver that's ready to go. We have a patient on the table. I'm ready to do the transplant. Should we proceed or should we not? Because if we make the wrong decision, the patient doesn't make it through the operation.
Very difficult decisions you have to make.
The Mayo Clinic has published their extensive experience and used these pressures of less than 35. You can proceed when the mean artery pressure is less than 35. 35 to 50, it depends on the PVR. As I mentioned, greater than 250 or less than 250. If it's greater than 50, we can't move forward. And interestingly enough, we have on a couple patients over the years, and patients that had unrecognized portal pulmonary hypertension, they made it through the case, and we'll talk about that in a minute, but not without it being a little bit dicey. So it can be done, but it's not the way you want to go.
Dr. Elwing?
So those parameters are what we shoot for. When we meet someone, we get their heart cath data, and then we treat them as aggressively as we can, as they'll allow, because everybody has different social situations, with the goals of meeting that hemodynamic criteria to allow them to be a transplant candidate if that's what they wish for. So this is a race against time. In pulmonary hypertension, we oftentimes don't target numbers, but this is the one condition where you have a targeted number and you're going to treat as aggressively as you need to reach that. And it's very, very challenging for these very sick patients. They may have encephalopathy, which makes them not think as clearly as you would like them to be able to be thinking on the daily basis, and then they're at home mixing ICU level medicines to be able to get themselves to transplant level. So it's complicated, but we support them as much as we can to try to get them every opportunity to be able to be transplanted.
Critical races against the clock, so they need the teamwork and the expertise that they get here at the University of Cincinnati Medical Center. Thank you both very much.
If I may add, it's extremely tricky when the patient is extremely ill. So they're in the ICU struggling from liver failure and portal pulmonary hypertension, and they have a 80-90% chance of dying from liver failure, but I can't take them to the operating room unless the pulmonary hypertension is managed. And that's when it is a race against clock. It's a race against time there as well, because what's going to get them first. But for me, it's kind of an easy measure because I can't do anything if the lungs aren't going to tolerate it. And so for me, it's more just waiting till someone gives me the okay to go. But that's where it really gets tricky and really gets hard for patients and families, and it really requires the best care that there is.
Excellent.
Thank you.
Thank you.